Hello everyone, and welcome to the Micro e-learning program from the Global Parkinson's Genetics Program and the Aligning Science Across Parkinson's. My name is Daniel Teixeira dos Santos, and I'm a movement disorder specialist at the Hospital de Clínicas de Porto Alegre. Today, I will talk about motor progression scores, which is a very relevant topic as these scores assess the motor function of Parkinson's disease, which is key for understanding the disease. Here is a brief overview of my presentation. First, I'm going to talk about the importance of studying motor progression in PD. Next, I will introduce some rating scales used to measure PD manifestations. Following that, I will present some outcomes of interest obtained from those scales. Finally, I will briefly touch upon some common pitfalls in using data from these scales and conclude by summarizing the key message of my presentation. So let's get started. PD is a neurodegenerative disease with motor and non-motor manifestations. Symptoms progressively worsen over time, leading to disability. In the early stages, bradykinesia, tremor, and rigidity are typically mild. However, as neurodegeneration advances, these symptoms worsen, and additional manifestations such as motor fluctuations and dyskinesias emerge. Generally, in later stages, axial deformities, dysphagia, gait instability, and falls become more evident. So, what is the MDS-UPDRS? It is a clinical scale that assesses motor and non-motor symptoms of PD. It does so by examining 65 clinical features, each scored on a scale from 0 to 4, with higher values indicating greater impairment. The scale is divided in 4 sections. Part 1 evaluates non-motor experience of daily living. Part 2 quantifies motor impairments in activities of daily living. Part 3 evaluates motor symptoms through a standardized neurological examination. And finally, Part 4 grades motor complications, such as dyskinesias and off periods. Regarding the Hoehn Yahr scale, it is much simpler. In this scale, patients are categorized from stages 1 to 5, based on the physician's overall impression of their motor capacity. This scale is formally incorporated within the MDS-UPDRS. There is also a modified version that includes intermediate stages 1.5 and 2.5, but these additions have limited utility due to a lack of validation. There are various ways to define outcomes in the MDS-UPDRS, but broadly they are categorized into global composite, subscores, and individual feature usage. In these slides, I will provide some examples for each category. Global composite scores are one of the most used, especially in clinical trials. One particular example is the sum of all the items in Part 3, which focuses on neurological examination. Subscores are useful for detailed and specific phenotyping. Some examples are the sum of axial and tremor scores. Lastly, some individual features can also be relevant. One example is a recent study assessing the time PD patients took to develop grade 2 or higher dyskinesia. In addition to the outcomes of interest I have mentioned before, I'd like to emphasize suggestions from this article authored by a group of experts. In the article, the authors propose clinically significant outcomes across 6 different domains, with at least 4 of them based on motor features. They suggest that an early-stage PD patient should exhibit one of the selected features in one domain within 5 years to be considered as having achieved this outcome. Although this study was conducted in PPMI data, the definitions proposed here could be applied to other research settings, such as cross-sectional data, due to the clinically relevant and consistent nature of the outcomes. This is why I believe this article should be mentioned here. As per the last topic of my presentation, I'd like to highlight some possible pitfalls you may face when dealing with motor progression scores. First, motor symptoms can be influenced by various clinical conditions, such as the examination being performed in either the on or off state, the patient undergoing deep brain stimulation treatment, insufficient or inadequate clinical treatment, and other conditions that can impair evaluation, such for example arthrosis. Additionally, the MDS-UPDRS is susceptible to measurement error. Previous studies have shown that this scale, although validated, may present poor longitudinal within-subject reliability and limited inter-rater reliability in mild symptoms. Lastly, it is important to consider what is clinically significant. For instance, if I were to inform you that a patient showed a 2-point decrease in their total MDS-UPDRS score since their last evaluation, would that be meaningful? These are crucial considerations to keep in mind. To conclude my presentation, here are my key messages. The primary clinical scale used for assessing motor manifestations in PD is the MDS-UPDRS, which evaluates 65 clinical features in a range from 0 to 4 each. The Hoehn Yahr provides a simple method for motor staging, ranging from 0 to 5. Features from the MDS-UPDRS can be analyzed as a global composite scores, subscores, or individual features, each with its own significance. Motor progression measures may be confounded by various factors, including clinical conditions, measurement errors, and the lack of clinical significance in some analyses. If you want to learn more about this topic, please check Module 7, Understanding the Genetics of Progression and Age at Onset, from the PD Genetics for Non-Geneticists course on the GP2 LMS. Thank you for listening and I hope you enjoyed the video.